and thank you for being a part of this IC. Biologics in ophthalmology is something new, and there are lots of information in literature, but it's not all together. So this IC was an attempt to bring it all together and give us an idea about how these drugs have changed treatment in many of the diseases. So we'll start with an overview of biologics and biosimilars. So what are biologics? They are a class of medicines that are derived from living organisms. And they can come from plants, animals, or bacteria. And they include a wide range, including blood products, tissue, vaccines, insulin, up to gene therapy for genetic disorders. So in ophthalmology, monoclonal antibodies are the mainstay or the most common drug that we use. So they work by targeting specific proteins and cells in the immune system with precise and therapeutic effect. It's produced using biotechnology, so therefore it's harder and more expensive to produce. And it's complex in nature, so most of these drugs are administered via injections or infusions. So WHO had introduced proprietary names for these antibodies in 1950, as early as 1950, and it was subsequently revised, in order that we have a clear identification of the drug or the molecule, and we all speak a common language worldwide, and it's also linked to the humanness related to immunogenicity. So this is the names that are given, and monoclonal antibodies, or what we all know as MABs, are basically of three types: chimeric, humanized, and human. So this is a regular antibody, and as we know that, as you can see, the chimeric antibody is partly human and partly mouse. Humanized is more of a human, and fully human is almost completely a human-like antibody. So difference between a chimeric and a humanized. A chimeric has 60 to 70% humanization, and the immunogenicity is medium, while a humanized is more towards human and therefore low immunogenicity. Likewise, a fully human antibody is 100% human and with very low immunogenicity. So as we've just gone through, these are the three types. And rituximab is it's a chimeric antibody, acts against CD20. Bevacizumab is humanized, acts against VEGF-A. And adalimumab is human and acts against TNF-alpha. So recombinant antibodies, again, based on the length of the antibody, can be divided into many types: full length, fragments, fusion, and bispecific. Full length is something that we've just discussed. Now coming to antibody fragments. So as the name suggests, antibody fragments are small portions and they retain the ability to bind to antigens. So there are different types of antibody fragments. It can fragment antibody, that is what FAB stands for. It can bind one antigen, or it can bind two antigens, or it can be a single chain with both heavy and light chains. Example is brolucizumab. So these molecules, since they are fragments, they are smaller molecules, and therefore you can pack in more of these molecules in a small volume, and because they are smaller, there's better tissue penetration. So that we know very well with brolucizumab. Recombinant, now the next type is FC fusion proteins. So this is an engineered product which combines the FC portion with a protein. So because of this reason, these molecules are larger, but it's precisely because of that the half-life is longer, better pharmacokinetic properties, and it increases the molecular stability. Examples are etanercept, which are used in rheumatoid arthritis and GIA, and aflibercept in ophthalm. Coming to bispecific antibodies, again, as the name suggests, it is an artificial protein that can simultaneously bind to two different types of antigen at the same time. So you have the first, so because of the two different antigens, you have better efficacy. And the first bispecific antibody that was approved was blinatumomab, and faricimab is what we are more familiar with in ophthalm. It combines to both VEGF and angiopoietin 2. Now in 2021, this nomenclature has been revised by WHO, and they are doing away with MABs altogether. So now we have to learn a second set of nomenclature. They've divided into 4 suffixes. So TUG, BART, MIG, and MENT. So TUG is basically an unmodified FC portion of the immunoglobulin. BART is an artificial. MIG is multi-specific, so that specific antibodies which I mentioned earlier comes under this group. And fragment is an antibiotic fragment, like brolucizumab with single chain, that comes under this group. So it can be either one of these 4 suffixes. And the infix, that is the portion just before the suffix, is based on the target tissue or the target system. For example, what we use in retina, bevacizumab, the C is against the cardiovascular, basically against the blood vessels. Now coming on to biosimilars. So what are biosimilars? They are defined as products which are highly similar to, but not the same, and it is, but has no clinically meaningful differences from the existing reference product. So what is the difference between biologics and biosimilars? Biologic is basically, it's a first molecule, it's an innovator, and it must demonstrate safety through extensive clinical trials. Example is Lucentis. As a biosimilar demonstrates similarity to the reference product. An example that we use is Razumab. Of course, because it's the first product, it's higher, there's a higher cost involved both in producing and to the end user, that is the patient. Biosimilars, the cost is lower, again, to produce and also to the end users. It takes around 10 to 15 years for development and clinical trials, while a biosimilar takes only 8 to 10 years. The biologic is patentable, while biosimilar doesn't need to have a patent. Again, what is the difference between a biosimilar and generic? These are complex molecules from living cells, while generics are smaller and it's chemically synthesized. A biosimilar is highly similar to the reference biological, but it's not the same because these are complex molecules. You can't really exactly replicate to the original molecule, while a generic is the exact copy of the original drug. And the approval is through complex pathways, while in a generic it's quicker. Higher cost is definitely involved, and a generic is lower cost. Biosimilar is a developing market, as we all know, while this is an established market. So antibiotics which we prescribe from one company to the other are all similar. I mean, generic it's the same, but biosimilar it's not like that. So to conclude, biologics have changed the way we treat diseases. It's an evolving field with newer molecules being developed as we speak. So we need to familiarize ourselves with its properties and indications. And biosimilars, as and when it comes for every molecule, it can reduce the cost of treatment. Thank you. So with this, I'd like to introduce the next speaker, Dr. Anju, Anju Suresh, who's the head of Orbit and Oculoplasty Services, Chaitanya Eye Hospital, Kollam and Trivandrum.
Good morning, everybody. Good morning, everybody. Today we'll deal with biologics and orbital inflammation. So at the beginning, I should mention that we have not yet started using. We are just getting more and more information about the possible biologics that can be used. So biologics are considered in non-infectious, non-malignant inflammations of the orbit, like in thyroid eye disease, orbital inflammations due to rheumatological conditions, and non-specific orbital inflammations. So this was a 47-year-old patient with Graves' disease. On mycophenolate, he presented with loss of vision in the left eye. So you can see his MRI picture. There is an increased size of all extraocular muscles. The optic nerve has lost its sinus curve and is stretched. So he is actually suffering from stretch optic neuropathy. And there is severe proptosis, increased orbital fat volume, etc. So he has to be treated with high dose IV methylprednisolone according to the ONTT protocol. But then after that, his proptosis is still there. His diplopia is still there, and his extraocular muscle movements are also affected. So what next? He can have either surgical orbital decompression or a course of orbital radiotherapy, or he can have injection teprotumumab. So what is teprotumumab? As she mentioned earlier, it's a monoclonal antibody, and MU means that it is fully human. Teprotumumab is a monoclonal antibody directed against the insulin-like growth factor 1. It competitively inhibits the receptor so that IGF cannot bind to the receptor. And there are no biosimilars available. And on the market, it is available as Tepeza. So why was IGF-1 receptor considered in thyroid eye diseases? So clinical molecular studies have shown that IGF-1 receptor and the TSH receptor exist as a physical and a functional complex on the cell membrane. So they act together, and this is called receptor crosstalk. This means that if the IGF-1 receptor is stimulated, the TSH receptor also gets stimulated, and vice versa. If we inhibit the IGF-1 receptor, that also inhibits the TSHR receptor. So when stimulated, they act together. Their downstream pathways are actually different. IGF-1R is a protein kinase receptor, and TSH works by the G protein coupled receptor. So together, they act synergistically to increase the production of hyaluronic acid and orbital fibroblast proliferation. And why teprotumumab in thyroid eye disease? Tepeza was actually developed for the treatment of metastatic solid organ tumors, but was found to be ineffective. However, studies in patients with thyroid eye disease, and the study was OPTIC and OPTIC-X. OPTIC, they studied 40 patients with thyroid eye disease, were given 8 injections of Tepeza, and the placebo group was given normal saline. 8 injections given over a period every 3 weeks for a period of 24 weeks. And at the end, the outcome studied was mainly proptosis. Other secondary outcome study were diplopia, extraocular movements, clinical activity scores, and the Graves orbitopathy quality of life scores. So it showed marked improvement. All patients showed marked improvement in proptosis. That is up to 80%, 83% of the patients improved as compared to 10% of the placebo group. And then the patients in the placebo group were then given an 24-week course of Tepeza for the next 24 weeks and observed after 48 weeks. So that is the OPTIC-X study or the OPTIC extension study. So this is a phase 3 trial of the drug, and this was submitted and they got US FDA approval for first line medical treatment of TED in 2020. So this approval is for USA, but not yet in the European Union or UGOGO guidelines also. So how will you administer? The initial dose is 10 mg per kilogram. Why 10 mg? It is to see if the patient can tolerate the medication. Followed by 20 mg per kilogram, which is the actual correct dose. This is given every 3 weeks for 8 doses. Why a dose of 20 mg per kilogram? Because at that dose, 90% of the IGF receptors are blocked. So administration, it is available as 500 mg lyophilized powder in a vial that should be diluted with 10 ml sterile water, and this should be added to a 100 ml infusion of saline if the total dose is less than 1800. If it is more than 1800, you use 250 ml normal saline. So what are the adverse effects? Like the name suggests, it's an insulin-like substance, growth factor. So when you block that, you should expect hyperglycemia. So hyperglycemia is seen in 10% of the study population. It is also a growth factor. Therefore, when you block the growth factor, you block the growth in all cells all over the body. So it results in hair loss, weight loss, gastrointestinal problems, menstrual disturbances, nail breakage, etc. And of course, infusion reaction is always a possible adverse effect. So the unexpected side effect was hearing loss, which actually they didn't recognize initially, but later on individual case reports have come that hearing loss, often permanent, results from use of Tepeza. And the contraindications are inflammatory bowel disease. It can cause reactivation of ulcerative colitis, etc. Obviously, in an uncontrolled diabetic patient, it's difficult to use, and pre-existing hearing impairment. Because hearing loss is often permanent, before starting on Tepeza, you have to do a pure tone audiometry. In the middle of the treatment, you have to do a pure tone audiometry, and at the end of the treatment. Hearing impairment occurs more in older patients, more at higher frequencies, and is often permanent in those who already had pre-existing mild hearing impairment. If the patient cannot afford Tepeza, a second line treatment that can be used for thyroid eye disease is tocilizumab, which is available as Actemra. So what is tocilizumab? Again, it is a monoclonal antibody, humanized monoclonal antibody, which means that the chance of infusion reaction is a little bit more than Tepeza. It is an interleukin-6 receptor, and biosimilars are also available. So what is interleukin-6? It is a part of the pro-inflammatory cytokine cascade present in the orbit in Graves' orbitopathy. It amplifies the T-cell mediated inflammation within the orbital tissues. So it was found that it is higher in patients with active disease of thyroid orbitopathy, and can act as a potential biomarker. So again, the IL-6 inhibitor attaches to the receptor on the cell membrane and blocks the action of IL-6. So this decreases the inflammation within the orbit, but it does not modify the disease process. Therefore, there is not much effect on proptosis or diplopia. However, it will improve the clinical activity scores. Dosage, it is given at 4 mg per kilogram IV every 4 weeks. And then you can increase to 8 mg per kilogram for the next 4 weeks, depending on the clinical response. It is given 800 mg per infusion IV, again diluted with normal saline. Subcutaneous form is also available. You get 0.9 ml of 162 mg of tocilizumab. And subcutaneous injections were developed to facilitate self-administration. So main adverse effect causes neutropenia. So the chance of activation of latent TB is more, chance of invasive fungal infections is more. And therefore the main contraindication is an absolute neutrophil count less than 2000. And of course infusion reaction. So this was a 50-year-old with non-specific orbital inflammation. You can see the slightly enlarged lateral rectus and the slightly enlarged lacrimal gland. He responded very well to IV systemic steroids. However, in a steroid intolerant or steroid resistant patient, as a third line option, second line is the use of immunosuppressives like methotrexate, etc. As a third line option, you can use rituximab. Again, biosimilars are also available. So rituximab acts on the CD20, is a protein present on the cell surface of B cells. So the Rituxan binds to the CD20 and forms a cap-like structure over the B cells, which makes it easily identifiable to the killer T cells and macrophages. And dosage, we follow the rheumatological protocol for orbital inflammation. That is 1000 mg IV infusion, day 1 and day 15. And you can follow it up if the response is not as adequate. So because it is a chimeric monoclonal antibody, you should pre-medicate with antihistamines, acetaminophen, 100 mg IV methylprednisolone, etc. and give as a very slow infusion. You start with 13 drops over 1 hour, then 26 drops the next hour, so over a period of 4 to 6 hours. And adverse effects, again immunosuppression. A special adverse effect is progressive multifocal leukoencephalopathy, which is a fatal disease with no known treatment, and also hepatitis B reactivation. So other agents under trial are the oral form of IGF-1 receptor monoclonal antibody, and we are trying to develop a TSH receptor blocking monoclonal antibody also. 2 IGF receptor antibodies which have just finished their phase 3 trials are IB1311 and veligrotug, which is going to be available in 2027. So in the future, thyroid eye disease will probably be managed with a combination of a IGF receptor monoclonal antibody and a TSH receptor blocking monoclonal antibody, which will ultimately be the treatment protocol. Thank you.
Thank you, Dr. Anju. I'd call the next speaker, Dr. Dilesh, who's will be speaking to us on biologics in retinal diseases. Dr. Dilesh is a consultant VR surgeon at Comtrust Hospital, Calicut.
Good morning, everyone. I'll be talking about biological drugs in retinal diseases. As we know, in the pre-biological era, that is before 2005, before the first biological drug, ranibizumab, got its FDA approval, we were talking in retinal diseases about the goal of treatment was rather the prevention of vision loss. And we were not talking about improvement in vision in chronic retinal diseases like diabetic retinopathy and wet AMD. But after the advent of these drugs, we started actually talking about preserving reading vision and improving vision in these patients. And the growth of the imaging technology in retina, like our OCT, and everything can be directly linked to this advent of these new drugs. Because before that, we had no reason to actually look at these OCT because we had nothing to offer them. And the financial aspect of this is that many of us became retina specialists actually due to these drugs. Everyone wants to do a short-term medical retina fellowship these days because there is actual money in it. And there has been a paradigm shift in management of all these diseases from neovascular AMD in that end of the life cycle to ROP, thanks to these drugs. The common pathway that most of these drugs addresses is the VEGF pathway. It is the final common pathway for most of these diseases. The hypoxia sets in initially, which causes release of VEGF from the RP and Muller cells, and these stimulate endothelial cell proliferation and vascular permeability through these pathways, as we can see. So coming to the basic structure, I will not dwell too deep into this because ma'am has already, Dr. Sheena has covered this already, and these are the common anti-VEGF that we use. We'll try to see each of them separately. Coming to our innovator molecule, which is our ranibizumab. Initially, it has been designed like initially a mouse is immunized with recombinant human VEGF, and this will result in monoclonal antibody formation within the spleen cells of the mouse, and we isolate the B cells, and using a hybridomer technology we amplify these monoclonal antibodies, and the mRNA coding for the CDR, the complementarity determinant region, is isolated, and then the DNA sequence is generated using RT-PCR, and then it is transferred to a phage vector, and finally this is synthesized using an E. coli. E. coli bacteria is what generates the final drug. So the final drug will have 95% human component and 5% murine component. So that makes it a humanized antibody. So it binds to VEGF-A, and because of its 95% human component, it has very low immunogenicity. And the molar dose in our intravitreal formulation will be 10.4 nanomoles, and the vitreous half-life is around 3 days. I will not cover the clinical aspects, we will just stick to the drug aspects and pharmacokinetic aspects of it. So there is very low systemic exposure of less than 0.01%. How is it different from the other drugs? In bevacizumab, the initial DNA sequence is generated through similar procedure from the mouse only, but later on the full antibody fragment is used in the case of bevacizumab. Both FC and Fab fragments are here, whereas in ranibizumab it's only the Fab fragment that is used. And another difference is that mammalian cell culture with Chinese hamster ovary cells is used in bevacizumab, whereas E. coli is used in ranibizumab. So being a larger molecule, it creates a it clears slower than ranibizumab from the vitreous. Effect is similar due to the difference in binding affinity in most of the conditions, but it is considered to be slightly superior in retinopathy of prematurity because of its longer half-life within the vitreous, and it has a slower systemic clearance, which also creates a little bit of systemic issues in ROP especially. Aflibercept is not a monoclonal antibody, it is a recombinant fusion protein, as Dr. Sheena said. So it actually has VEGF-R1 and VEGF-R2 receptors bound to the constant heavy chains, and VEGF-A, VEGF-B and PIGF actually bind to this molecule. They are trapped within it, and so hence the name VEGF trap. So it has the least immunogenicity among all the anti-VEGF because there is no murine component here, it is almost fully human. And the vitreous half-life is also longer at 7 days, and the molar dose is slightly higher than ranibizumab of 17.4 nanomoles. Because of these things, it supports longer dosing intervals, it is more binding affinity, therefore it is considered superior to ranibizumab in large PEDs, DMEs with poor vision, etc. And brolucizumab, as it is a smaller molecule, single chain variable fragment is the only thing present here. Only the variable light chain and heavy chain are linked with a peptide linker. And it's a very small molecule of 26 kilodalton, and as a result it has a very high molar dose of 231 nanomoles. The half-life is not that long, but because of the higher molar dose it stays in the eye much longer, and it also has greater tissue penetration due to a smaller molecule. Theoretically it should have lower immunogenicity because there is no FC fragment, but practically what we see is that there is a higher incidence of intraocular inflammation of 2.2 to 4.4%. Why is it so? Because it causes anti-drug antibodies. Uh, there is even patients who are receiving it for the first time have been shown to have anti-drug antibodies because it is said to have cross-reactivity to unknown environmental antigens. So because of this, there is an increased risk of intraocular inflammation, even occlusive vasculitis and severe vision loss. Coming to the other pathway that these molecules address is the angiopoietin pathway. Normally the angiopoietin 1 pathway binds the Tie2 receptor and causes vascular stabilization, whereas angiopoietin 2 binds to the same receptor and causes vascular destabilization. And chronic retinal diseases, it causes an increase in angiopoietin 2. So faricimab is a drug which binds both VEGF as well as angiopoietin 2, and it is also synthesized from CHO, Chinese hamster ovary cells. It is a slightly larger molecule of 149 kilodaltons, but it has a higher intravitreal dose and a higher molar dose, and also a longer vitreous half-life of 7.5 days. So this will give it a longer action of dosing interval of up to 16 weeks. It also has reports of intraocular inflammation slightly more than your ranibizumab and aflibercept, but slightly less than brolucizumab. And rare reports of occlusive vasculitis too. Anti-drug antibodies have been reported in them also. Biosimilars, actually Dr. Sheena already covered. So in this, the protein sequence is taken from the reference drug, and the amino acid sequence is directly identified, and it is reverse translated to generate the DNA sequence. And this is later cloned into mammalian vectors and to generate ranibizumab. Several biosimilars are already available in India for ranibizumab. Aflibercept biosimilars are on the way. Their adverse event profile and clinical efficacy are similar to the parent molecule. The some adverse event that's been recorded is mostly due to the logistic issues rather than the drug molecule itself, inflammations and all. Coming to gene therapy, Luxturna is the molecule that is already available, and this is gene therapy directed against biallelic RP65 mutation associated retinal dystrophy. It is used in Leber's congenital amaurosis and retinitis pigmentosa. It showed promising results of 43% of patients improved around 9.8 letters, and these gains persisted at 3 to 4 years. This is a one-time subretinal injection, and the cost as of now is prohibitively high. Bilateral treatment will cost around 7.2 crores in Indian money as of now. And the newer drugs that are coming up in this are tarcocimab tedromer or KSI301. This is an anti-VEGF antibody biopolymer conjugate. This biopolymerate binds the drug and extends the intraocular durability. Phase 2 trials have shown good efficacy with extended dosing interval up to 16 weeks. Phase 3 trials are ongoing now. Sozinibercept is another thing which can bind VEGF C and D. So these are not the primary molecules, so it can be used as an adjuvant along with VEGF A inhibitors. Phase 3 trials, however, did not meet the primary endpoints. Further research is going on around this lines. And RGX314 is a subretinal gene therapy. Actually, it causes sustained release of anti-VEGF within the eye. So this is another molecule which is also in trial. So this is a treatment for wet AMD, a gene therapy which releases anti-VEGF, which is also in phase 2 or 3 trials. And gene therapy for inherited retinal disorders is something that should be coming up in the next 5 to 10 years. It has been used to treat X-linked RP, which is associated with the RPGR gene. Botavec and Larzova are promising molecules in this regard. And choroideremia, there is the BBJ one, which is also in trials. ABCA4 associated Stargardt disease is another disease they are looking at, and these two molecules are showing promising early results. LCA and OPGX, these are LCA caused by mutations other than our genes that the Luxturna targets, the RP65. This is a gene therapy targeting this particular gene, GUCYD2. And this one is particularly interesting, the MCO010 by nanoscope pharmaceuticals. This is said to be gene agnostic. So RP, it's very difficult because the RP has more than 120 genes causing retinitis pigmentosa, but this is said to be gene agnostic. It codes for opsin gene, so it's said to improve regardless of the mutation that causes the RP, it's said to improve vision. As of now, the gains are minor. 3-line ETDRS gain sustained at 2.5 years has been shown, but this sounds very interesting. In conclusion, I have to say that biologicals have revolutionized treatment of retinal diseases, and newer molecules can lessen treatment burden for chronic retinal diseases. And gene therapy is another horizon, as they changed our paradigm of management in chronic retinal diseases about 20 years ago. Possible paradigm shift can come in inherited retinal disorders down the line. Thank you.
Thank you, Dilesh, for that nice overview of what we are doing now and also what is in the future. I'd like to call upon the next speaker, Dr. Anabi. She's a senior consultant cataract surgeon and heads the UVA services at Tony Fernandez Eye Hospital, Alva. She'll be speaking to us about biologics and intraocular inflammation.
So my topic is biologics in ocular inflammatory diseases. Let's first see the principles of management of uveitis. First and foremost is control of inflammation, which is the primary goal. It can be done by induction, that is initial control with steroids, and suppression or long-term control with immunosuppressives. Second one is prevent visual loss, then prevent structural damage to the eye due to persistent inflammation. So there is a step ladder approach to uveitis management. First is corticosteroids, then we move on to conventional immunosuppressives, and finally biologics. So I'll be talking about biologics. So this is the step ladder pattern. We start the patient with systemic steroids, 1 to 1.5 milligram per kilogram body weight. And if the uveitis is not controlled in 4 to 6 weeks, we will move on to conventional immunosuppressives. If there is inadequate response in 3 to 6 months, in spite of maximum tolerated dose, we move on to biologics. And first line is adalimumab, infliximab, and golimumab. Second line is tocilizumab and rituximab. So what are the indications for immunosuppressives? When there is worsening of inflammation while on high-dose steroids, when there is active uveitis while on systemic steroids, dosed at 30 milligram or 0.5 milligram per kilogram per day, relapse of uveitis after reduction of doses to less than 7 to 10 milligram per day, and as a steroid sparing therapy to avoid the side effects, and in severe sight-threatening conditions. So what are the indications for severe inflammation? It is impairment of visual function less than 20 by 100. If it is a bilateral disease, if there is vitreous haze of more than or equal to 2, if there is macular or optic nerve involvement, when the retinal vessels are involved, macular edema and exudative detachment, ocular structural complications that threaten the visual function, if the disease is recurrent or chronic. Diseases where biologics can be started early in treatment are Behçet's disease, sympathetic ophthalmia, VKH, rheumatoid necrotizing scleritis, and Wegener's granulomatosis, relapsing polychondritis with scleritis, and juvenile idiopathic arthritis. There are certain relative indications also. It is recurrent intermediate uveitis, retinal vasculitis, severe chronic iridocyclitis, and sarcoid-associated uveitis. I'm not going to the classification. The first drug is adalimumab. That is the only FDA-approved molecule for treatment of non-infectious uveitis. It is used in treatment of juvenile idiopathic arthritis, Behçet's disease, VKH, sarcoid, ankylosing spondylitis, birdshot chorioretinitis, pars planitis, and idiopathic uveitis. It is given as a subcutaneous infection, loading dose of 80 milligram at week 0, then a dose of 40 milligram at week 1, followed by maintenance doses of 40 milligram given at 2 weeks interval thereafter. The cost is 25,000 for 40 milligram, but biosimilars are available for 7,000 for 40 milligram. Next drug is infliximab. It is not approved by FDA for treatment of non-infectious uveitis. The indications are almost similar, and the dose is 5 milligram per kilogram at week 0 to 6, followed by 4 to 8 weekly. The cost is 25,000 for 100 milligram. Golimumab, it is less frequently used. It is used in treatment of uveitis associated with Behçet's disease, JIA associated uveitis, and HLA-B27 associated uveitis. Dose is 50 milligram every 4 weeks subcutaneous, or an IV loading dose of 2 milligram per kilogram every 4 weeks, then extended to 8 weeks. The cost is 22,000 for 50 milligram. Tocilizumab, it is used in the treatment of uveitis associated with Behçet's, birdshot choroiditis, again JIA, sympathetic ophthalmia, and ocular sarcoidosis. The indications are almost the same for all days. Doses subcutaneous 162 milligram weekly, or IV 4 to 8 milligram per kilogram weekly. Cost is 25,000 for 400 milligram. Rituximab, that is anti-CD20 drug, it is used in refractory Behçet's disease, JIA refractory to anti-TNF agents, ANCA-positive vasculitis, non-infective scleritis, VKH and HLA-B27 associated uveitis, primary intraocular lymphoma, and polyangiitis with ocular and orbital involvement. The dose is 500 to 1000 milligram IV 2 weeks apart, repeated every 4 to 6 months. The biosimilars cost is for 500 milligram, it is 20,000. The latest is JAK inhibitors. It is synthetic disease modifying anti-rheumatic drug. It is available as tablets. It is used in non-infectious uveitis refractory to conventional and biological immunosuppressives. Tofacitinib is the most commonly used one. It is weight dependent dose. If the weight is more than 40 kg, it is 5 milligram twice daily or 11 milligram extended release once daily. If the weight is between 20 to 40, it is 4 milligram twice daily. And if the weight is between 10 to 20, it is 3.2 milligram twice daily, available as an oral suspension. The cost is less, it is 1,100 for 60 tablets, 5 milligram. So how do you evaluate the patient pre-treatment? You have to do a complete blood count with platelet count. Then you have to do a liver function test, blood urea, creatinine, electrolytes, urine analysis, and uric acid. Cardiovascular evaluation should be done because some of the drugs can cause cardiac failure. The cholesterol level, you have to check BP, assess the cardiac status, and rule out cardiac failure. Then we have to rule out demyelinating diseases because infliximab is known to cause demyelination. Rule out infections like tuberculosis, HIV, hepatitis B, and hepatitis C. Enquire about history of malignancy for self and in family. Then you have to rule out autoimmune diseases because if an autoimmune disease is present, the biologics use will be different. Then you have to have an immunization record. Patients should be immunized up to date for pneumococcal, influenza, and hepatitis B vaccine. A word of caution about pregnancy till 5 months after stopping the last dose of biologics. Patients receiving anti-TNF therapy should not have live virus vaccine including varicella, oral polio, or rabies. Patient should be aware of the adverse effects of the drug and consult a doctor if the patient develops fever, sore throat, or bleeding. How do you monitor a patient on biologics? Blood workup should be done every 2 to 4 weeks for 2 to 3 months, then every 6 to 8 weeks. And uveitis follow-up should be done 4 to 6 weeks after starting biologics, then 4 to 6 weekly until the uveitis is controlled. And once stable, it is once in 2 to 4 months. What is the criteria used to decide adjusting the systemic therapy? Whenever there is a decrease in vision, increase in AC cells in flare, increase in vitreous haze, increase in the chorioretinal lesions, and if there is retinal vascular involvement or macular or optic nerve involvement, then we should think of increasing the dose. What to do if one immunomodulatory agent is ineffective? We should think about treatment non-compliance, and we have to reconsider the diagnosis, that is to rule out infection or look for masquerade syndrome. This is a 15-year-old female who came to us with complaints of flutters of 1 year duration. When she presented, the vision was 660 in right eye and 618 in the left eye. Slit lamp examination showed anterior vitreous phase cells of 1+. She gave history of taking biologics for the last 6 months, but they were not satisfied with the response. So they stopped the medication and came to us. When she came to us, the fundus picture was this feature suggestive of retinal vasculitis was present, and OCT showed macular edema. So we started initially the patient on systemic steroids. We sent the patient for a rheumatological consultation, and she was again started on adalimumab. And after 3 weeks of starting biologics, she was put on MMF also, and she responded very well. Macular edema subsided. So what is the approach if one anti-TNF is ineffective? You should escalate the dose to maximum tolerated therapeutic dose, that is increase infliximab to 5 to 10 milligram per kilogram every 4 weeks, or increase the frequency of adalimumab to weekly, or switch to another anti-TNF such as golimumab or certolizumab, or you should start combined treatment. In this patient, they have started biologics with mycophenolate mofetil, or you should think about second-line biologics. This is again a 27-year-old female. She is a non-case of ankylosing spondylitis. She is from Odisha. She was on biologics because of recurrent anterior uveitis and her systemic problem. Here also the patient stopped the medication, and then she came to us with recurrence of anterior uveitis. She was sent to rheumatologist, and now she is again started on biologic. So this raises the question when to stop the medication. Treatment has to be continued for 2 years after the disease is inactive, and interval between the doses is increased and then slowly stopped in 12 months. Suppose the patient is on combination with the anti-metabolite, then we have to stop the anti-metabolite first and then the biology. So it is a shared decision making. Ophthalmologist makes a diagnosis, comes to a differential diagnosis and do the investigations. We make a preliminary diagnosis. We do the local therapy and the ocular monitoring. When we send the patient to the rheumatologist, they will rule out systemic diseases. They do further investigations and manage the systemic drug therapy. So to summarize, a symptomatic patient while on biologics, if there is no response, we have to rule out infection and masquerade, and it can be either a primary non-response or a secondary non-response. If it is a primary non-response, we have to switch to a different class of medication. If it is secondary non-response, we have to do a dose adjustment or add other immunomodulators. If these two are not effective, then we have to switch within the same drug class. Thank you.
Thank you, Dr. Anabi, for that nice overview. Uveitis is, biologics are used extensively in uveitis and has really changed how it is treated. Our next speaker is Dr. Revathi Ramesh. She is a senior consultant and heads Neuro-Ophthalmology Services at Tony Fernandez Eye Hospital, Alba. She'll be speaking about to us about biologics in neuro-ophthalmology.
Good morning, everybody. I'll go into the topic immediately. In neuro-ophthalmology, the neuro-ophthalmic disorders to be considered for treatment with the biologics are optic neuritis, optic neuropathies, especially that associated with giant cell arteritis, myasthenia gravis, and thyroid optic neuropathy. Thyroid has already been dealt with in detail by my colleague, so I'll stick to the first three. First, to understand these disease processes, the normal blood-brain barrier prevents any influx of any objects into any molecules into the CNS. This normal blood-brain barrier consists of the endothelial cells, the tight junctions between endothelial cells, and can I have this? Okay. The tight junctions between endothelial cells, the pericytes which are near the endothelial cells, and this forms the blood-brain barrier. Along with this, the astrocytes, food processes are closely related to the endothelial cells. They provide the biochemical support and thus indirectly form part of the blood-brain barrier. Demyelinating diseases and any CNS inflammation requires a massive influx of T cells into the CNS, and this usually happens by the T cells putting forwards cellular adhesion molecules like integrin, and these react with the endothelial vascular adhesion molecules. The combination allows these T cells to breach the blood-brain barrier and enter into the CNS by a process called diapedesis or transcystosis. And once the T cell is inside the CNS, it causes neuronal damage and myelin damage, demyelination. The B cells also contribute to the pathogenesis. They activate the autoreactive T cells which attack the myelin sheath, produce pro-inflammatory cytokines and chemokines and neurotoxic substances. So B and T cell mechanisms are involved. Optic neuritis, we all know, is an inflammation of the optic nerve. It may be typical, which is associated with multiple sclerosis, or atypical, associated with neuromyelitis optica, spectrum disorder, or NMOSD, and myelin oligodendrocyte glycoprotein associated disorders, MOGAD. Less common diseases are there. I won't be going into those. An acute attack of optic neuritis is first treated with high-dose short-term IV methylprednisolone, followed by oral steroids. If this doesn't work, then plasma exchange is tried. If that too does not work, we go on to traditional disease-modifying therapies, like in multiple sclerosis, we use interferons or glatiramer acetate. These drugs reduce the number of lesions, but they are not so effective against relapses. When relapse occurs, that is when biologics come into play. The primary objective of these biologics is to slow the disease progress, reduce frequency of relapses, and minimize nerve damage. In multiple sclerosis, targeted therapy with biologics may be against B cell, that is anti-CD20 mainly. These are rituximab, ocrelizumab, and ofatumumab. And then against the T cells, we have natalizumab, which is a selective adhesion molecule inhibitor. Rituximab is an anti-CD20 monoclonal antibodies mentioned again and again by my colleagues. This in multiple sclerosis is an off-label use. Here, the dosage is initially you have 1,000 milligram infusions weekly for 2 weeks, and maintenance is 1,000 milligrams infused twice within 2 weeks, within every 6 months. The cost of this drug, as Dr. Anabi has already mentioned, is about 20,000, or usually get it for 35,000, the original molecule, for 500 milligrams. And this is the least of the least expensive of the biologics. Ocrelizumab is a first-line approved treatment in multiple sclerosis. The dosage is like this, and it is prohibitively expensive. And natalizumab is a selective adhesion molecule inhibitor, SAM inhibitor. It inhibits the reaction between the T cells and the endothelial cells, as I have mentioned earlier, and so it prevents the diapedesis of the T cells into the CNS, and thus it brings down the inflammation, and new lesions are reduced. There's a significant reduction in multiple sclerosis relapse and disease progression thanks to this drug. It is administered as an intravenous infusion of 300 milligrams IV every 4 weeks. The cost is about 1 lakh per dose. The most common adverse effects of natalizumab include infusion-related symptoms, infections, arthralgias, gastroenteritis, depression, rash, but the most dreaded complication, as my colleague also mentioned, is progressive multifocal leukoencephalopathy, which may be fatal, and this is because of the reactivation of John Cunningham virus. So it is usually advised only for those patients who are JC virus antibody negative. In these patients, the fear of PML is much less. However, there is another problem over here with natalizumab. There is a rebound on premature cessation of treatment. The endpoint in treatment of recurrent multiple sclerosis is recurrent relapsing multiple sclerosis is NEDA, that is no evidence of disease activity. NEDA 3 is there should be no relapses, no increase in disability as measured by EDSS, no new or active drugs in the annual MRI scan. Or NEDA 4, which includes all these three, plus there is measurement of brain atrophy as the fourth component. Another endpoint measured is knee pad, that is no evidence of progression of disease activity. It is neither 3 or 4, plus you measure walking tests are done and a 9-hole peg test as an indicator of arm function. This is to measure whether the drug was slowing the progressive accumulation of disability in the disease. Coming to NMOSD group of disorders, the discovery of aquaporin 4 IgG has converted our thinking of this as a demyelinating disease to an astrocytopathy. It's actually an astrocytopathy with consequential myelin and neuronal dysfunction. Aquaporin 4 is expressed throughout the body and within the CNS, especially it is predominantly located in the plasma membrane of the food process of the astrocytes, which we have already seen these food processes indirectly form part of the blood-brain barrier, which must be breached for these diseases to occur. In NMOSD also, both B and T cell mechanisms form part of the pathogenesis. The disease-modifying therapies used over here are cetralizumab, inebilizumab, and eculizumab, which have different ways of attacking the disease process. They release relapse rate, especially in seropositive NMOSD patients. Cetralizumab is now the first IL-6 receptor antagonist FDA is approved for treatment of NMOSD. It's used, the dose is 120 milligram subcutaneous on weeks 0, 2, and 4, and then followed by 120 milligram subcutaneous every 4 weeks. The contraindications are hypersensitivity reaction to the medication, and we have to rule out the 2 Bs, hepatitis B and TB. And even during treatment, you have to keep an eye open for reappearance or recrudescence of these two diseases. Eculizumab is a CD5 inhibitor which is used in NMOSD treatment, and the dosage is such, again, the cost is really prohibitive, 3 to 4 lakhs per dose. So, serious side effects of all CD20 antagonists, especially eculizumab, are appearance of meningococcal and other infections. In fact, meningococcal vaccination at least 2 weeks prior to eculizumab treatment is advised, and even then, during the follow-up, you have to keep an eye open for meningitis and other infections, even if the patient has been vaccinated. Coming to myelin oligodendrocyte glycoprotein associated antibody associated disease, or MOGAD, this is a relatively new disease that has been recognized. Children are predominantly affected. Optic neuritis, ADEM, and transverse myelitis are the 3 modes of presentation. And several drugs, since it is recently recognized, it is found to be either bilateral or unilateral, monophasic or relapsing. The drugs that have been are being studied are the off-label therapies employed in the treatment of other CNS inflammatory disorders. The drugs that are being studied are rituximab, tocilizumab, and inebilizumab, besides others. And here, inebilizumab has been found to be more efficient than rituximab. Coming to ischemic optic neuropathy, the GCA-associated anti-ischemic optic neuropathy, all of us know, steroids form the mainstay of treatment here. Tocilizumab is found to show promise, is showing promise in the treatment of this condition. Before I check out, a small word about immune checkpoint inhibitors, or ICIs. Some tumor cells in our body, they produce immune checkpoints which prevent the body T cells from killing the tumor cells. These ICIs, they inhibit this process, and they allow the tumor cells to be killed by T cells. That is, they exogenously enhance the immune system. These are cancers in the other systems, that is not in the eye. The drugs that are being studied are ipilimumab and nivolumab. So how does the ophthalmologist come into this picture? It's because of the ocular immune-related adverse events that is usually commonly seen are myasthenia gravis and ophthalmoplegia with these drugs, and that is how we enter the picture. And talking of myasthenia gravis, You have refractive myasthenia gravis, ocular myasthenia gravis, and now we have ICI's induced myasthenia gravis. Here the drugs that are being studied for treatment of these types of myasthenia gravis are again rituximab, eculizumab, and rivolizumab. These several other drugs are under trial for treatment of myasthenia gravis. Thank you for your patient hearing. That is about the biologicals and neuro-ophthalmology.
Thank you, Dr. Revati. I think we are just in time and we may not have, does any of the audience have any questions? If not, then we'll wrap up. We have another 5 minutes? 8:55. So we'll close the session. Thank you all. Thank you to my co-instructors.